Do you
Yeah.
see my screen?
Yes, you can use your PowerPoint. You can see the Zoom, but
Can I make it large?
yeah, I can.
From
Yeah.
the beginning. Okay. So thank you very much for having me and letting me contribute to yet another seminar with a talk on craniopharyngiomas. It's very hard to follow exquisite talks by Fred and especially Henry, and I really want to compliment both of them for what they have shown, and especially Henry is progressively pushing me to become an endoscopic surgeon. But for the purpose of today's talk, I want to complement his talk by trying to argue the other way, why open surgery remains an important tool for this particular disease. And I apologize for some redundancy and some repeat topics and slides that you will see, but it will hopefully help with completeness to cover this topic. Nothing to disclose. So we've heard some excellent talks today about craniopharyngiomas, and we learned many options. However, for more than 80 years, the question really remained, what is the right approach to deal with this? And I think especially when you're not yet the specialist as Henry is with endoscopy, the big question is, how do I personally learn this? How do I learn open surgery for this? Is it microscopic? Should it be endoscopic? Should it be minimal invasive? Should it be aggressive or should it be conservative? Because most of this comes from experience. And if you all remember, the incidence of this disease is rare. It's about 1 in a million, which makes 400 cases per year in the United States. Most of us see about 5 per year in our centers. So even a good person in a good center sees a very limited number of cases to learn this. And in endoscopic cases, you need a certain amount of experience to be as skillful as Henry is, whereas most of us in residency have maybe seen 1,000 craniotomies. So it's not a bad thing to think about a craniotomy as a good tool at the beginning as you acquire your endoscopic skills through pituitary surgery, for example. So what made us think about craniopharyngioma to begin with? Just to repeat, most cases show a supra and paracellular tumor with solid and cystic components, and CAT scans show often calcifications, more so in children's. And patients clinically often present with endocrine dysfunctions, which we have talked about. Classic clinical issues were visual and neurological and cognitive compromise as a triad in conjunction with medical morbidity. This is just a slide for completeness. The patient really comes to you once you have the first scan and wants to know two things. The patient wants to know, what are my treatment options? And for the purpose of this talk, I want to talk about surgical resection strategies, and then briefly about biopsy and cyst aspiration and stereotactic intracystic delivery of active substances. The second thing they're asking is, what is my risk of surgery? And you are the specialist as a physician, so you know it much better than the patient, but you can tell them the usual top 10, infection, bleeding, wound healing difficulties, stroke, coma, death, and so on. But in reality, they don't really know how much is much. It very much depends on your approach, on your experience. So a lot of it is iatrogenic, and the second part is hormonal. So don't make decisions based on the initial CAT scan when you see the patient in the ER and tell them you need surgery and I'm going to take this out. There are way too many options to approach a lesion like this, which is like a 4 centimeter partially cystic, partially solid lesion, which could be a number of things, but get really several pre-surgical scans. The risk is not insignificant because resection is difficult. And it's difficult both because of anatomy, and this tumor is buried deep inside the brain, and it's like catching a bird out of a bird cage without opening that bird cage. And it's also difficult because of the pathology. These tumors are very variable. They can be very sticky, they can be viscous, they're often infiltrative, and they're often calcified, all of which complicates your surgery. There are two schools of thought we've heard about, either gross total resection for all patients, and that decreases your chance of recurrence, but that still is 1/3, or subtotal resection with cyst decompression. And I think we should all aim for gross total resection, but it isn't a disaster if resection is subtotal, because I think that question has been largely answered. There are excellent reviews from the UCSF group showing that superiority of conservative resection, near total resection, and adjuvant radiation therapy in craniopharyngioma, because for all these cases that were described in the literature, progression-free survival is insignificantly inferior in subtotal resection, followed by adjuvant radiation, and overall survival is only minimally better, but insignificantly better in gross total resections. The big difference is that the postoperative endocrine status is significantly better in patients that did not have that last piece of tumor removed to achieve a gross total resection. So if there's a tiny piece of tumor left, subtotal resection followed by adjuvant radiation had less morbidity. The question was finally, how and when should we radiate? That question is also currently answered. Current treatment of choice is 3D conformal IMRT, stereotactic small field radiation, 56 gray and 28 fractions delivered through 6 portals, gives you a good coverage and control rate of about 90% at 10 years. When should we do that radiation? The answer in adults is likely at salvage, so you don't win by radiating immediately post-op, wait until post-surgical changes settle and the tumor recurs at 3 years or later, and then you get good difference of side effects through your waiting period and good tumor control. So again, to today's talk, how should we pick the right surgical approach when we start our practice? So after coming out of surgery, residency, going into fellowship or after fellowship, you know, you need to learn your anatomy, and then it's because of you and your experience. So how did I learn this? Well, first you need to think about the anatomy. It's all about the sella, and obviously there are open and endonasal approaches available. We need to remember the paracellular region is a very delicate area. It's adjacent to the optic pathways. We said the pituitary, hypothalamus, the vessels at the skull base, and the mammillary bodies. And this has a huge influence on your comorbidity or morbidity to begin with. Vision, hormones, mental status, sleep-wake cycles, obesity, we talked about this. The paracellular region is really a delicate area, and you need to study, even I still need to study before each case, cisterns, nerves, and vessels. And I think one needs to rethink, you know, where does this tumor sit and how do I get there best, as Henry said? Where is my best window? In addition, I always want to look at the blood supply. Although in craniopharyngiomas, this seems to be poorly understood. Most solid tumor parts are supplied via the pituitary and hypothalamic vessels, and the cystic part shows rather little vessels. A few cases in the literature show it can grow into the wall of the lateral ventricle and parasitize it, but that remains under debate. Caveat is, watch your perforators and chiasma vessels. You cannot sacrifice vessels that are shared between eloquent structures. So the first thing is when you study your pre-surgical scans, look at the infundibulum and chiasm, and I can tell you from experience, it's very hard to see the infundibulum. So start with the chiasm. Most people have a normal chiasm, which means the chiasm is located directly above the optic and the pituitary. 15% have what's called a prefixed chiasm, that the chiasm is anterior, short optic nerves, which makes your access very difficult. And 15% have the opposite. The chiasm is posterior to the pituitary with long optic nerves, which is nice for surgery. Remember what this means for our surgical approach. A normal chiasm and a prominent bony sella, either anterior clinoids and tuberculum or posterior, will limit your access to the suprasellar and sellar area. So when I look at this first, I define tumor into pre-infundibular, transinfundibular, and retroinfundibular. And as Henry has mentioned, the problem is the pituitary stalk. You can't always see it on the images. And even Yashagil's series of 160s, he said he could only identify at surgery the stalk in about half of these cases and only preserve it in about 1/3, which means really experienced hands have difficulties with this tool. So realize this is a challenge. Translating into 70% of patients usually need some form of hormonal substitution after surgery. There are multiple classifications that are in use. An early one here by Maurice Chou divided tumors in pediatric patients into sellar, infundibular, intraventricular, and global tumors. Later, Yashagil went and divided this more by growth pattern into tumors growing anteriorly, superiorly, posteriorly, or inferiorly. And then you can have multiple subdivisions depending on how this grows laterally. But this is too complicated for me, and I was very happy to see that Henry picked the same classification I did. I like the one that was brought up by Kasper, that divides it into type 1, pre-infundibular, type 2, supra-infundibular or in the stalk, type 3, posterior infundibular, and type 4 is purely in the ventricle. So I think approaches should be chosen based on tumor features with particular attention to the chiasm and the stalk. So when you look at the tumor configuration, pay attention to shape and size and location of the solid tumor portion as much as size and location of the cysts. I think the cysts can provide you with working space. Look at areas of calcifications. Look at distortion of normal anatomy, where it could be your first problem you encounter. Whereas potential invasion of the third ventricle visible on T2 or flares on the pre-surgical MRI scan, which part of the tumor reaches the surface and where is it best accessible through cisterns, and is there associated hydrocephalus? The second component is really your experience and your familiarity with an approach. There are often several equally suitable approaches possible to the same tumor. There's no shame in picking one, just pick the one that you are good at. And obviously it depends on your center as well. Do you have intraoperative imaging available or not? Some people swear on it, some people use DTIs, but basic CT MRI imaging usually works well. And then patient parameters. So study the details, get high resolution MRI scan, CAT scans with CTA, and if you can or want DTI to delineate the optic nerves. And I want to show you this example, which is the same tumor from the beginning. So this shows a largely cystic but partially solid lesion. The cystic portion fills the third ventricle. The solid portion really sits retrochiasmatic, so it's a craniopharyngioma type 2 and 4 mixed. And that made me go after this in an open fashion when I learned this. So this is the time to consent the patient. You have good imaging. The question is for what? So first surgical option is, and I want to note this briefly, is there need for shunting? Because quite a number of patients, older and children, present with hydrocephalus. And I think if signs and symptoms are acutely related to hydrocephalus, an EVD or a shunt is suitable. EVD if you want to operate in the next few days, shunt if you want to delay it somewhat or you have to. But remember, bilateral drainage may be necessary if the ventricle is entrapped. Bring the shunts on both sides together into the same shunt valve, so not one ventricle drains faster than the other. They should drain against the same resistance. And if they don't, the problem can be that the overdraining ventricle causes midline shift, and you get actually herniation to midline structure. The second problem described by Yajigal nicely was people can get acutely worse after shunting. That happens in a few cases where you basically decompress the hydrocephalus, and now the tumor with the cyst is pushing against less resistance. So kinking of the optic apparatus can cause a sudden decrease in visual field and function. But you also have to rule out that you're overdraining and you may develop some subdurals. So rescan the patient early, you may accelerate your intervention. And now let's come to the surgical options. Obviously, there are many surgical craniotomy options at hand. That tells you nobody has the holy grail here and knows the answer. And in some cases, when the tumor is extensive and not just in the midline, you may actually need more than one approach in more than one sitting. So there's no shame in saying I may not be able to take this out in a single session. It is diligent planning what's required here. So modern choices are individualized by patients, by surgeon. I recommend all beginners to learn and read the chapter in Apuzo's fantastic book on brain surgery and complication avoidance. We've heard the transsphenoidal side from Henry and Fred Gentili very well, and I want to talk a little bit more about open approaches. Reiterate, transsphenoidal surgery and management is great, and it's a good way to learn this. For type 1 lesions, intracellular, largely defined to the subventricular, third ventricle space, transnasal surgery and resection is the method of choice and can show, as in this case, you preserve the optic nerve and the pituitary stalk really well. Now, most modern transsphenoidal endoscopic series have shown that Craniopharyngioma surgery is suitable for endoscopic surgery if they have clear features, mainly median, intracellular, and likely subchiasmatic location for sure, small or to medium, with no real paracellular solid component, and especially if they grow along the stalk. And if you're a specialist, you can deal with tumors reaching posterior, inferior, or into the third ventricle. Now I want to show you, for historic reasons, frontal interhemispheric approaches for open surgery. I have not used this for a craniopharyngioma myself, just because it wasn't necessary, but I think the main indication is there used to be tumors that are purely intraventricular or extending into the lateral ventricle. You can't reach that through a nasal approach. The problem is if you come from the top down, and you see this in Yajagil's drawing on the bottoms, you have very limited visibility for neurovascular structures near the cella, and it's a very long reach. So if the tumor has a solid component at the bottom, it's not smart to come down from the top. If you do come down from the top, you can either go intraforniceal, transcallosal, or you can go transventricular. Your choice. I prefer to go transventricular for lots of tumors in the ventricle, because I don't like to separate the fornices in the middle and pull on them. But you have to be aware during surgery and on pre-surgical imaging about vessels, fornix, and keep your callosotomy to a minimum, less than 2 centimeters for sure. I think whenever you cut a white matter tract, there's a risk of cognitive damage. So if you can avoid it, don't go this way. Other approaches may be more suitable. My go-to approach initially was a right-sided terional approach. It is preferred for the right-hand surgeon, does not retract on the dominant hemisphere, very short working distances, excellent access to the cisterns, direct approach to the suprasellar area with good viewing angles and good topography. Now, when you do this, you do it 100 times in other cases, you just are very familiar with this. It allows you perfect approach to the circus of Willis. And when you learn aneurysm clipping, you use that a lot. Gives you excellent visibility of both optic nerves. So head position is standard, slightly hyperextended. You can combine it with an anterior clinoidectomy. I always remove the lateral sphenoid wing, and you can do a wide urotomy, which gives you good access. This is how this looks. And you have various approaches that you can use. And I want to show you in this picture, on the left lower corner, number 3 is the main working corridor, is likely the opticocarotic triangle, seen in the picture in the middle. You see the tumor is protruding between the optic nerve and the vessels displaced laterally, and you can often nicely dissect the craniopharyngioma out from this angle. And this works really well in children too. There's a beautiful chapter by Michael Scott and Ed Smith in the book by Ed Laws. Now, what would I do for this first patient that I showed to you with this type 2-4 suprainfundibular retrochiasmatic intraventricular craniopharyngioma? So I decided to go in via terional low anterior approach because I wanted to come in from the right and be behind the chiasm. So I got my pre-surgical imaging. You can see that we have the CTA with little calcifications only, but the tumor is largely midline. And the tumor could be nearly totally removed at index surgery. I did open the lamina terminalis to look at the top and behind the chiasm, and that's where I was actually very lucky. There was clearly a sharing of vessels between the solid tumor component and the back side of the chiasm. So I had to leave a small retrochiasmatic calcified remnant, and we did not have any stroke. The patient did perfectly well post-surgery. You can also see the lowest coronal picture in the lower row shows that you often get, with the right side approach, excellent resection of the left-sided cyst wall on the opposing side of the third ventricle wall. It's more difficult to see the ipsilateral side. This is a similar tumor, but it's off midline and it's more calcified. So also type 2-4, and the tumor shows the solid portion towards the left, so it's easy to come in from the right, use the cyst as your working space. Same approach, and I was able to take this out through a terional approach from the right with a gross total resection. Now here's a case where I came in from the left, and why did I do so? If you look at the tumor images, you see that the tumor is solid on the right side. It sits rather low and it touches the top of the basilar tip. I couldn't tell either chiasm really well or pituitary stalk. And the patient already had a right-sided shunt placed by one of my colleagues. So I felt this is best approach to the left side. In the lower row, red box, you see we were able to separate out most of the basilar tip nicely, but there's a tiny remnant of the capsule of the tumor where it was draped over the perforators coming off the basilar tip, and I did not feel comfortable sacrificing any of the perforators. And to decrease morbidity, I left this behind, and the patient was 2 years later treated with radiation. Second option is go subfrontal uni or bilateral. This is an approach Dr. Sami prefers. It gives you excellent visualization of the optic nerves, and especially through the lamina terminalis to get inside into the third ventricle with long viewing axis. You see the carotids on both sides very well. You can also combine it with resection of the forks if you want to reach up. And
we got 2 more minutes.
Yeah, in children, that brings you to a nice wide access to the suprasellar areas. If need be, you can extend it like the middle picture shows temporally, so you get a lateral view, take the orbital roof out, and you have very large access to a complicated tumor area. 2 pearls, get a plain CT scan with scout images to look at the frontal sinus, bring your craniotomy as far as you can to the midline and as low as you can to the orbital roof, which gives you great viewing angles, and then you should be able to sneak in there. This is one of these cases that I did with a subfrontal approach and was able to take this out successfully. This is Yajigil's picture about combining subfrontal with transventricular tumors. I haven't seen that, but please keep that in mind. Finally, I want to show you 2 more slides for minimal invasive approaches. This is a slide of a colleague of mine who came to us with this off midline calcified tumor with a cystic component. He said he absolutely would not want to take days off from his normal life as a physician, and he didn't want to accept any morbidity. So we discussed this at length, and he opted for a biopsy with stereotactic cyst aspiration, which took us 1 hour to do, confirmed craniopharyngioma. We radiated the tumor as an outpatient with fractionated CyberKnife 5 fractions, so the patient didn't miss out any of this, and the patient developed some post-surgical cyst re-enlargement, which we could drain with the catheter implantation. So this patient got away with 2 minimal invasive surgeries of 1 hour each and did excellent in terms of post-surgical control. Last slide. Newer techniques that are available have allowed us to look in complex tumors, especially in children, to also use minimal invasive techniques for intratumoral brachytherapy. On the left side, you see the Freiburg experience summarized by Triple's paper in New Frontiers. On the right side, you see probably the best series of all by Dr. Yu from the Navy General Hospital in Beijing. Multicystic tumors in children that are largely cystic with no solid component can well be aspirated with stereotactic techniques and then filled with P32 colloid. The radioactive colloid will deliver high dose beta emission, 200 gray to the cyst wall, and these tumors show equal response rates to gross total resection, with 85% of tumors showing excellent tumor reduction or remnants that do not grow and are stable at 20 years. I've just analyzed his largest series. It's going to be published hopefully within the next 6 months. And I think it is an excellent technique we should be aware of and not be shy of sending patients to referral centers. So what have we learned from all this today? Key to progression-free survival remains to control tumor growth. A gentle conservative surgery should be aimed at gross total, but if it is subtotal, just be aware of diligent follow-up. Pick the surgical approach that you master best based on the anatomy and your skill set. Given equal outcomes, there's no shame in leaving a tiny piece behind to not inflict morbidity, because treatment complications define quality of life. And at this point, 10-year survival is above 90% in most cases. So realize that these patients are your walking business card, and you want to do a good job because they will sing your praise or destroy you in the community. Thank you very much.
Thank you. Thank you, Eric. That's been a fantastic overview of the approaches. And Sever, the conclusion comes down to the quality of life, as you said.
I think so.
Yeah, I mean, we can take one comment from the panelist or question from the panelist, and then move on to the conclusion. Anyone wants to make a comment? Okay, Ibrahim. Sorry, Ibrahim, carry on. I'll ask Bill after that.
Thank you very much indeed, Ekkehard. Thank you for pointing this, that the aim is a gross total resection. And it is there inside this surgery that you decide whether you can do complete excision, radical excision, partial excision,